Welcome, everybody, to Chai with Scintillating Stars, a signature webinar series hosted by ISNM, where we foster the exchange of ideas, knowledge, and technical expertise in the field of nuclear medicine. I am Chitra Saxena, Vice President of ISNM, and I am delighted to welcome you to today's session. This event is proudly supported by Dr. Amol Thakurkar, who is a president of ISNM and a distinguished leader in clinical research and nuclear medicine. We are also joined by Dr. Khushbu Gupta, chair of membership at ISNM, nuclear medicine physician, along with Dr. Deepak Kable, who has recently taken on a role of secretary of ISNM and is already contributing with great enthusiasm. Now it's my privilege and a true honor to introduce our legendary guest today, an inspiration, visionary, and compassionate nuclear medicine physician, scientist, and leader whose experience continues to shape our future in field of nuclear medicine. It's welcome, and it's Dr. C.S. Ball. He is a distinguished leader in the field of nuclear medicine. He is serving as a dean and professor and head of nuclear medicine AIIMS in New Delhi. He's a fellow of three premier in Indian science academics. Dr. Ball is internationally recognized for his pioneering work. His notable achievements includes he received twice Dr. Henry Wagner Jr. Best Abstract Award at SNMI USA in 2021 and 2022. He's a global first to initiate the DM program in therapeutic nuclear medicine. Dr. Ball introduced novel clinical concepts such as lobar ablation. He's a pioneer of low dose iodine 131 ablation and clinical and nuclear medicine in India. He's a former president of Indian Thyroid Society. Welcome, Dr. Ball. I can go on and on and on with all these accolades about you. Welcome to our webinar.
Thank you, Chitra, and thank you, Amol, for inviting me. And we know ISNM, when I joined nuclear medicine way back in '88, I think from that time I know ISNM, and every meeting, whenever I attend, I always make it point to attend the ISNM dinners, and we always invite ISNM to educate us in 80s and 90s when the India nuclear medicine was not in back on that big name. But fortunately, the nuclear medicine of India has now come up in last 4 decades and it is doing well. And I can say that we are no less than any other part of the world, so we are doing it. But it was happy to know that all this happened because of there are few individuals, enthusiasts who made the Indian nuclear medicine to the global stage for their contribution. And I am happy we can share our thoughts and how we can go to the next level, how we can help each other and achieve our desired goal.
Definitely, definitely. It's an honor and privilege to have you here, Dr. Bal, with us for this podcast webinar. You certainly are one of the scintillating stars, the brighter ones from India for this webinar. And as Chitra just introduced you, you've had a very interesting and astonishing journey with a lot of highs. So let's walk through the beginnings of your journey. What first kind of drew you towards this field of nuclear medicine? Because back then, when you started nuclear medicine training in India, it was not doing that well as compared to the last couple of decades. So what drew you to nuclear medicine, and what pivotal experiences have shaped your path of becoming finally the dean and or the head of AIIMS nuclear medicine in New Delhi?
Yeah, it is very interesting. You will find very surprising. I think if somebody has to believe in destiny, it is I cannot less than that. I think the destiny child. I am a destiny child. I was best graduate of my batch. I was having a gold medal in many subjects, including clinical medicine and surgery. And as a young boy, when you join medical school, you've always been flamboyant. Surgeons look at them, and you get always wanted to be a surgeon. So that was in 80s, and when everybody wants to be surgeon. So I wanted to be surgeon. So I joined the University Department of Surgery, and within 6 months I realized this is not a cup of my tea, because every day you go and cut and stitch and cut and stitch. So no need of using brain power. So I got frustrated. Then I wanted, if I told if I will not be a surgeon, let me try with a physician. So I joined medicine also. So after 1 month, I left medicine. There everyday causes of splenomegaly, causes of fever, and all this routine stuff. I didn't get excited. So then I somebody told me, if you want to be a scientist, then look for medical research which will give you enthusiasm. So I went to All India Institute, interacted with biochemist, physiologist, pharmacologist, pathologist, microbiologist, because I was in Delhi. So I went with my friends here and there, discussed with them. But I was really impressed by a biophysicist. His name is Professor R.K. Misra, who was the student of Hans Selye. You must know Hans Selye was the father of steroid biochemistry, who the fright and fright concept he introduced. So I was within talking to him in 30 minutes. I got impressed. I told, yes, here is a branch I should join. So I wrote the entrance exam. I qualified and joined biophysics within 3 years. I had 4 major publications, and one publication comes in Feb Biochemistry Journal, European Federation Biochemistry Journal, in 14 days time. That was my mentor told me that we have never sent any publication 100% time. It has to come for revision, but this time the paper accepted in total. The work was drug DNA interaction using computer simulation model way back in 1985. When the computer, there was only one computer in all in Institute, and I was working in that computer with my mentor. So because
Nice.
there are 3 PhD student, and the MD student will be always lower. The PhD student get time in the daytime, so MD student has to go work in the night. So, and I have no problem. I always voracious reader. I used to work in the night. So I used to go in the 9 o'clock after my dinner, work whole night, then come back in the morning, sleep for a few hours, then get up again, go back to the department. That's why within my MD period, in my 3 years, I published 4 international journals, including Journal of Molecular Biology. So it was that time it's considered very prestigious journal. So I had presented my work in the Hamburg Cancer Congress, 16th Cancer Congress in Hamburg. And looking at my work, Professor Govindan, who was in Quebec Laval University, invited me to do postdoctoral fellowship, PDF. But when I came back and discussed with my seniors and very peers, colleagues, they told you doing pure research, you will get frustrated. So why don't you go to a branch where you can do both research and patient care? That's how I landed up in nuclear medicine. so so I did my nuclear medicine training from Radiation Medicine Center, Mumbai. During my training, so I applied for my national board, and I was the first till until 1988 and 89. I was the first person in the history of national board in nuclear medicine who passed theory and practical in one chance. First chance I passed. So then I joined the All India Institute of Medical Sciences. When I joined there was nothing. Compared to RMC and INMAS, All India Institute Department of Nuclear Medicine used to have one gamma camera, and that was to 4 or 5 bone scan and 10 renograms, that's all. And sometimes we do HIDA scan, sometimes we do GI bleeding, and there was no teaching, no research, nothing, just a service department. And when I joined, I was unfortunate for me or fortunate, I don't know. Professor Basu, who was our head, he was in Nepal. He was on sabbatical. Dr. Gopinathan Nair, who was number 2, he went to IAEA. And then Dr. Padhi went to Commonwealth Fellowship in UK. So I was the only person as a senior resident, as well as looking after the whole clinic, patient work, and everything. Then Dr. Padhi told me that you should look after the thyroid cancer. So he gave me the diary, and I look at the diary, and it was the waiting period is 2 years. because we had only one bed, and everybody used to get, whether young, old, male, female, child, adult, everybody will get 200 millicurie, irrespective of any level of cancer. So I looked at the diary, and then I told his 2 years is very big. So by the time RMC had 2,000 thyroid cancer patients compared to AIIMS only 204 patients. So I talked to Dr. Padi. I wanted to do a low dose randomized control trial, but he told no, not possible. You have to give everybody 200. That is our protocol. Then it took almost 3 to 4 months to convince him that let's try something. They told, okay, we can't buy extra iodine. I told, okay. Iodine, in those days, radiation medicine center used to have a lot of iodine because they don't have to buy anything. They are just because they're part of BRC. But AIIMS has to purchase. So for buying anything, you have to additional funding. So in those days, BRC, Saturday, Sunday used to be closed. So they have to send the iodine on Friday. And the iodine will come in the airport, lying there for 3 days, and on Monday it will be collected. So I had an idea, why don't you collect those iodine on Saturday and treat these remnant ablation patient? And then this is how I started. And to get extra one dose from that 30 millicurie, 50 millicurie, 100 millicurie, 150 millicurie, it took me 6 years to complete only 149 patients, 6 years. And that's what anything anybody says, anything you cannot do, I have a habit. If you say you can't do it, I will do it. So that is my personality trait. If somebody say it is impossible, I will tell, let me try. So it was in whole thyroid cancer. If you read, there was a aphorism that time. In thyroid cancer, you cannot have any randomized control trial. And I did the first ever randomized control trial in thyroid cancer, having 149 patients. Demonstrate two important things came out from that. And that I presented in one of the SNM meeting in 95, June. And again, Dr. Suresh Srivastav, Dr. Joe Mantle helped me to present. And that time residents, I was ad hoc assistant professor then there is no funding supported from the institute. So they supported my registration, my stay and travel. In fact, Dr. Joe Mantle arranged me $1,500 to be as a trainee in Kettering Hospital. That is how I could present. And that 6 weeks I spent with him. And that time I wrote that paper, manuscript, and submitted before leaving US. And within 6 weeks, that paper got published in Cancer. In those days, there was no JCO, there was no other important journal. That was Cancer was everybody used to read that time. And it was published in Cancer. I always wanted, if you published in Nuclear Medicine Journal, thyroid, because no endocrinologist in America, they read in thyroid in Nuclear Medicine Journal. So that is why I wanted to publish in Cancer. And interestingly, that within 1 month, there was an editorial written on that work by Arnie Majaperi. So it was that is how our relationship with Arnie started. So then one question raised by Goran Londell from Karolinska Institute, that you have demonstrated 30 millicurie to 50 millicurie is optimum, because we demonstrated a very interesting observation. We made anything, if you give more than 30, the ablation rate becomes plateau. And in 30 to 50 millicurie, you achieve 30,000 Gray, which is required. So anything you give extra is only ablating the salivary glands and gonads. So that was the interesting observation. And then Dr. Londell wrote that what will be the minimum dose? I told, okay, I wrote the response to the author letter. So I told, okay, we'll do another trial. And let's do at 15 millicurie, 20 millicurie, 25 millicurie, 30 millicurie, 35 millicurie, 40, 45, 50. And we found interestingly that anything if you give 30 millicurie and above is same, there is no difference. But if you give less than 25 millicurie, the success rate is less compared to the more. And that is how we published in 2004. Another 8 years it took to publish in 96 and then 2004. In this time I published in JCO 509 patients. So now people have read my work, and a lot of people referred patients for low dose ablation, and I got a good number of patients. So 509 patients, that is why published in JCM. And before 2012, this interesting observation happened. Dr. Martin Stulberg, who is a very good friend of mine, he came to India. We had an interaction, and he whole day he told, Oh, I always give 100 millicurie. It works very well. 30 millicurie, if this doesn't work. I got irritated at the end of the day. I told, why don't you go and do a trial and prove me wrong? He took it late personally. He told, okay, I'll do. That is how the basis of estimable trial started. And then similarly, once the estimable trial, high-low trial also similar. Then Dr. Malik, Ujjwal Malik, who was the key investigator in the high-low trial, wanted me to part of the trial. Then when I submitted this proposal to All India Institute, our ethics committee told, you have already 2 publications, and saying that, why don't you start as a referee and see which you are right or they are right. And in 2015, in 2015 in World Thyroid Congress in Paris, Dr. Schumberger was holding that meeting. So I was going up to the climb and he was standing there. So he told, congratulations, you are right. I told, what? I just got shocked. I told, what is right? He told, you will see. In that Congress, high-low trial and estimable trial results were no abstract, blank. They were published, they were neck to neck competition they wanted to publish, and they presented the data. The hall was almost beamed. Everybody was standing in the side of the, I was sitting next to the Majafari, and Dr. Arni Majafari, I was sitting next to him, and we were discussing. And the result presented, and they told 30 millicuries, same as anything 100 millicuries. So somebody asked Dr. Arni Majafari, what is your opinion about these two trials when results are identical? He told, I know Dr. Bal has published it in 96 because he was working in India, so people didn't accept. Now I think his step is vindicated. So that is how I got the publication, and out of 10 publication on a small 30 millicurie, I think 3 paper published from our center, and remaining 9 are from remaining 7 are from other center. That's why in 2015 it came to the guideline, and finally it's been accepted. So then we had another area where a lot of people used to go for second surgery, and when I reviewed my histology, 95% of them had a normal thyroid. I told, if there is a normal thyroid, why somebody has to subject her neck for another surgery? Why can't we? Then I looked into the literature, and as usual, nuclear medicine people are little timid. They are very conservative rather. So they told, okay, if you give the intact lobe, there will be radiation thyroid, sky will fall, there will be, patient will be like a small atom bomb. So once what happened, there was a school teacher, one of my friend, Dr. Dr. Sunil Chumbar, he is the head of department, currently head of the department. That time he was assistant professor. He told Dr. Bal, I was unfortunate that I operated on a school teacher, and the recurrent laryngeal nerve was abnormal, and I cut it. Now she has got only one laryngeal nerve, and if I go and I do it the other side, she may be totally paralyzed. Can you do something? So always God gives you always the opportunity to challenge you. So I told, okay, I have never given anybody with intact lobe, because our nuclear medicine literature says you cannot give with a lot of thyroid. So I admitted the patient, very scared what to do. So give only 30 millicurie. So in the morning, evening, 4 days, I went every time to see if the sky is falling or the patient is having a severe throat pain and something. Nothing happened. And the patient went home. And when 6 months later she came for the whole body scan, there was nothing in the neck. Dr. Chumbar used to sit on the fifth floor surgery OPD, and I was in the ground floor. I ran with the patient and the scan. I told Dr. Chumbar, he's gone, everything is fine. So he was surprised. He told, with 30 minutes, all the lobe gone. I told, yes. That's how we started the lobar ablation concept. And we have now more than 2,000 patients with the lobar ablation. And we have recently published a propensity score matched analysis on 1,500 patients, demonstrating that if you do a two-step surgery and give iodine, and you do only one-step surgery, hemithyroidectomy followed by iodine, the results in long-term 10 years follow-up is identical. So only thing that in lobar ablation, if you give less than 50 millicurie, the success rate is around 68 to 70%. And if your remnant ablation is around 85 to 90%. So that's the only difference. So I have an idea to give the small dose recombinant TSH and improve the but it never happened because I didn't get any money from the company or anybody to do that trial, because you have to buy because at All India Institute, any trial you want to do, you cannot charge the patient. You have to do it free of cost. So we have to arrange funding. So I could not arrange. So that is one of my unfulfilled dream, I could not do that. So I am hoping that if you give full dose, it will be much worse. But if you can give small dose, 1/3, 0.3, instead of 0.9 milligram, you can give 0.3 2 days. I think you can achieve you can improve the success rate. I always say what the surgeon left, you can do with the first dose. And what is left is like a remnant ablation. So you can, at 2 steps, you can finish that. That's all.
Yeah, yeah. Interesting. So you've got a lot of things going on for you. Got good opportunities and right place at the right time has kind of helped you a lot to gain what you've gained. Of course, your own rigor and your perseverance and attitude that let me try, let me see, never say die attitude kind of help. So you've achieved a lot of wisdom as you've over the past several decades that you've practiced. And if you reflect on that, is there anything that you would have done differently, professionally or personally, now knowing what you know 3 or 4 decades later since you started?
Yeah, we had first thing which I realized immediately after that we don't have enough manpower. We don't have the trained people. And diploma in nuclear medicine, when you're talking to the endocrinologist or a cardiologist or a nephrologist or a urologist, they're all overqualified. They're 12 years. After doing diploma in nuclear medicine, they always they look down upon the nuclear medicine people. They are not properly qualified. In fact, when I wanted to do the thyroid clinic, and All India Institute, my endocrinology professor was very upset. He told me, you can't have a thyroid clinic. We are endocrinologists. We are qualified to do that. So I told, okay. So then I convinced our HOD, Dr. Basu and Dr. Malhotra and Dr. Padi. Dr. Padi that time was in Vienna. He was not very sure that we can have an MD program. We had only one MD program by Dr. B.K. Das in Sanjay Gandhi, which is not in a very big good shape because, as you know, there is institutional. So Dr. Das was not much time in Sanjay Gandhi. So All India Institute actually had a formal MD program started in 95. So we had started with 6 students, and then now we have got 24 residents in our department. Then in 2008, I realized that the therapy is taking its shape when the lutetium-8 and PSMA is not yet made the channel. And I thought here is the time when we should have a dedicated therapist. So I submitted the proposal, but as usual, they always ask, is there anywhere, any other place you have this program? I told, no, we can start first. But unfortunately, as you know, when you are not the chair of the department, so when you go to these big meetings, they told, okay, tell your HOD to write. So Dr. Malhotra was a nuclear cardiologist who was never interested in therapy. So when I became chair of the department in 2013, and within 1 year, we got the approval for I convinced them all India Institute can be also leader in some field. It's not necessary that we always ask if it's there something. We can be the leader. So fortunately, they convinced, and we started our fellowship program, which is called in India DM in therapeutic nuclear medicine in 2015. So now it's 10 years. So in between, we also realized that just training the doctors is not enough. You don't have CNMT type degree in India. We have only a diploma after BSc. They do 1 year training called DMRIT, which is not adequately to handle to deal with the SPECT-CT, PET-CT. And so I convinced the Dr. Malhotra that we should have a MSc program. So then he told, okay, you write the syllabus, and we convinced the academic committee, staff council, and finally we got approval. Now we have got 15 MSc student nuclear medicine technology every year. So 2 years, 30. So total now my department has got 75 students in any point of time. And then we have a PhD program, and personally I have supervised 6 chief guide, 6 PhDs, and most of them are abroad, well settled. And I am happy that my PhD scholars helped me a lot, because whatever I can give them idea, but somebody has to have hands to do it day in, day out, collect the data, compile the data, analyze, then we can give them ideas. So that's what somebody has to do it. That's how we achieved something. If you say what I could have done, I wish I would have been in my 30s. The real nuclear medicine is taking this shape, and unfortunately, or fortunately, whatever my remaining part of my life, I will definitely dedicate myself to the nuclear medicine therapy. I was offered a fellowship in 91. You will be surprised to know 91 in UCLA. And Dr. Satoshi Minosema and I myself were interviewed by UCLA team, and I was selected there. But my family pressure that I should continue working in nuclear medicine. My wife told me one thing: do America need you or you need America? I told definitely I need America. America doesn't need it. They have got enough people. Then why don't you stay back and work something which you can be proud of? So that is why the turning point in my life. I joined ad hoc assistant professor in 91. Until 2000, until 98, I continued working ad hoc when my peers, Dr. Gambhir and Dr. Gambhir, Dr. Malot, Dr. Mittal, all of them were like associate professor, additional professor. I was still struggling as ad hoc assistant for 7 years. But God always says it is the average out. So I became professor first compared to both of them. So in 2003, I became additional professor, and 2005, I became a full-time professor by open selection. So I was,
Nice.
that is how.
So, and I'm sure you have peers and contemporaries and all the opportunities you got and some you turned down during your path. Are there any key mentors that you recollect, or any role models who influenced you and your professional growth during this time, and any lessons that you learned from them that you would like to comment on?
My key mentor, I would suggest two person I would definitely mention. One is Professor Narendra Nair from Radiation Medicine Center, who was really give me free hand to do research in thyroid. My first experience in nuclear medicine is on thyroid, and that's my rest of my love affair for the rest of my life. So he gave me a topic. While you have already published 4 international papers and you know how to do research, why don't you design a trial and tell me? That time, this iopanoic acid and ipodate were the two which are very popular that time. So how to control the severe thyrotoxicosis as soon as possible. So this is how I designed this study. I went to the BRC library, and then the Wadia Hospital Library, and then there was the Reproductive Center Institute Library. In those days, there was no internet, and you get the nowadays you don't have to lift it in little finger. You can get all this information in your mobile phone also. So I decided that I should do in how to control severe thyrotoxicosis as early as possible and make them ready to be given radioactive iodine. But when I looked at the literature, it was mentioned that if you give the cold iodine, you can never be able to treat with them in radioactive iodine. Then I looked into the actual what is the paper. In 1956, there was a radiologist who wrote a letter to the editor in JCM, Journal of Clinical Endocrinology Metabolism, saying that if you give the cold iodine, that is in those days, ultrasound was not that big way. That was everybody used to have for gallbladder, they used to have these oral contrast agents, orographene, cholecystography, all these drugs. So I just, but nobody had asked this question, how the iodine behaves kinetics in hyperthyroid patient. It was all 74 patients they had studied, is all euthyroid patient who came for gallbladder evaluation, and they did their serial uptake and they didn't find the uptake. It takes some few months to years to come back. But that is okay in a euthyroid individual. But what happens in a hyperthyroid? The biological, your metabolic rate is quite different. So I tried to do this study, and Dr. Nair managed to get hyaluronic acid, sodium iodate in for the 10 patients. So I wanted to do 10 patients, but there was some issues in our radiation medicine center. I could only recruit 6 patients, and I demonstrated that was like a small pilot study to demonstrate. And then they asked me that no technologist will help you. You have to do all your T3 assay, T4 assay, T4 index, and TSH assay. And then you have to collect the data, you have to do the uptake and everything. And so that's a good opportunity because I was already trained to do the research. So or compared to other my colleagues who are after MBBS, they have come to do the diploma. So I was well educated to get the research. So I did that, but it was going well. And surprisingly, we found if you off the telepack, we are used to give 1 gram per day for 7 days and then off. Then 7th day, 14th day, 21 day, and 28th day, we used to do uptake. And interestingly, we found by the end of 2 weeks, if it is hyponicus acid is stopped, 92% patients are ready to be given radioactive, which is a new finding. And then in the exam, once it is over, then everybody was going home in 31st of July. I went to Dr. Nair. I told sir, fortunately I topped the batch. So I was getting distinction. So I went to Dr. Nair and told, sir, tomorrow I am going to New Delhi. I will be likely to work in All India Institute. He told, you cannot go unless you submit the abstract and on my table and the full paper and you will go. I told, okay, sir. I have written the thesis, but no, that is thesis never published. You have to write in the form of JNM and submit it. So another 15 days struggling, going in the hot sun and trying to find out the library and putting the everything. So the last day, and on 14th of August, I went to Dr. Nair with the manuscript. In those days, everything has to be done manually, and I just give the charts, graphs, everything on his table, and he told, okay, now you can go. So when I come to All India Institute, there was a vacancy to be available on 1st of January. So from August till 31st of December, I worked All India Institute without any salary. I worked continue because I wanted to continue working to appear for my DNB exam. So this 6 months, I got opportunity to read a lot of literature and prepare myself, and I passed my theory and then passed the practical. So I was the first person before joining senior residency in nuclear medicine, already MD in biophysics and DNB in nuclear medicine with in DRM also. So when I told this Dr. Gopinath Nair and Dr. Padhi that we have submitted a paper to JNM, they all laughed. They told, okay, JNM is a physics journal. They never publish any Indian articles. So you just submit. It will not be. But 15 days, 20 days later, when I get a call from Dr. Nair saying that, Bal, our paper has been submitted. Only two authors, Bal and Nair. I was shocked. So I wrote the remaining part and revision of the all the reviewers' comments and submitted. And my first work in nuclear medicine got published in JNM. That is what it gives me a lot of enthusiasm. Just if you work, whether you work in America or India or anywhere, if your work is good, your idea is good, people will publish it. So that was what my seniors who had challenged that it will be never published, but got published in
Nice,
JNM.
nice.
So Dr. Paddy is one person who always challenged me in whether it is small dose, he was not agreeing. In for this paper also he was not agreeing. But sometimes when you get a challenging person as your mentor, you always think out of box. You always try to prove your worth, what you are. So, but I had a very little time to work with under him. Dr. Gopinath Nair left in March of 90. I just joined in 1st January 90 as a senior resident, and he left on 31st March. 3 months I had worked with him. Then immediately after that, Dr. Padhi went for Commonwealth Fellowship to UK. And then after coming back, he was for trying to go to IAEA. So Dr. Gopinath Nair took him to IAEA. So my turn was third to go to IAEA, but unfortunately, Dr. Mauricio Dandi asked me, why don't you come and join IAEA? I told, let me see first how you like. So he told, okay, you come as a locum for 3 months. So if you like, you can continue your job. And if you don't like, you can go back. So after end of 2 months, he gave me a review the thyroid cancer book, which is published by IAEA to revise and all this. So I finished in 2 months time. And the first day of third month, I went and told, sorry, I want to go back to India. He told, why people are crazy to come to IAEA, you want to go back? I told, sir, I don't like this job. I am missing my patients. I want to go back. So I just came back and continued working. And you will be surprised to know in my 35 years in All India Institute in nuclear medicine department, My longest leave is 3 months for PET-CT training in Kettering Hospital, Ohio, under Dr. Mantle, and 2 months my sabbatical in IIA. My total career, 5 months I have taken leave from the institute. For your information, in All India Institute, every 5 year service you put, you are entitled for 1 month sabbatical. So in my 35 years, I am entitled for 7 years. I have not even taken 7 months. I have taken 5 months leave in my. So I loved my job. I loved my students. I love my patients, and I always never thought if you love something, it will never a task. You, I even sometimes I used to work till 9 o'clock, 10 o'clock in the night. Nobody has told me to stop, and why don't you working so long? Or nobody has encouraged me why you leave. But I always encourage. I always loved working. So this department, which has never a teaching department, never a just a small service department. I have started with 1 bed in nuclear medicine. Now I have got 30 beds in nuclear medicine, 30 beds. And we had never a teaching program. Now we have 75 students from all specialty of nuclear medicine subspecialty, whether residency or fellowship or senior residency and MSc program, PhD program, all them. I had, when I became head of the department, I had three vows for myself. One is to increase the number of beds from 1 to 10, but I have fortunately ended up with having 30 beds. So I wanted to establish a DM program, which in the first year of my chairmanship, I got the DM program done. Third, I wanted to establish a PET-MR facility, which we have just placed the order. So before my superannuation, the PET-MR will be on the department. So this.
Nice. So you fulfill all your aims and objectives in your short, stint as the dean. It's not short actually; it's pretty long, almost 12, 13 years. So obviously you love your research, but you also love your patients, and that's what led you to this field, because you were not happy with surgery, medicine, you were not happy with the IAEA job. So you basically have been involved in clinical work as well as research work. And how do you end up balancing both and being great in both? Because a lot of young faculty have a hard time to focus on what to give priority. So any words of advice for this balancing between clinical and research work for the young professionals?
Yes, for I think for the young people, I tell you, if you have a very clear understanding what you are going to do, you will achieve it. If you are confused what I am going to do this or do that, then I think it doesn't matter what subspecialty you are going or what specialty is. If you are dedicated to your work, you will definitely excel. That's my. If you remember in 80s and even in the early 90s, when All India Institute, I wanted to go to biophysics department. I was offered a radiology residency program. My wife asked in my batch of 410 people, the boy who failed in all subjects become radiologist. My wife told, okay, you want to be Arun Ponda? That is his name was Dr. Arun Ponda. I told, no, I want to be researcher. I want to be a scientist. That's how I ended up in biophysics and nuclear medicine and all this life I wanted to. You see what has happened in 90s and radiology. Earlier generation radiology was there was not equipments, there was not many brilliant students. But what happened in lately? All bright. If in All India Institute as a dean, I see the top 10 people opt for radiology. So branch need also good people. So earlier, what happened in 80s and 90s, even early 2010, nuclear medicine, people who didn't get anything, they just entered into nuclear medicine. That's why if you cannot, you need people who have love for the subject, they will take the subject to the next level. That is my first. If I'm telling you, if I would have been anatomist, I would have also famous as anatomist. That doesn't matter, because whatever work you want to do, you should love your work. You should give your best. That is what it does, immaterial, whatever. So in India, we are subject specialist, but in US, they are disease specialist. My daughter, who has been 12 years done oncology, now is only says, Papa, I accept myeloma, I don't know anything about oncology. So if I have to do my service, I have to call the consultant in the myeloma, in acute leukemia or lymphoma to give their advice. I never do, because last 12 years I am doing it only myeloma. Similarly, I told in All India Institute, I always tell people, you do 10 things, doesn't matter, because not like in US, there are some 200 oncologists in UAB and 5 of them are dedicated for myeloma. It's okay. But in All India Institute, we have got only 10 faculty members and 2 of them non-medical. So we have left with 8. So everybody cannot do only. But what your heart will be with something. You want to, suppose you want to do excel in biopsy. So in PGI Chandigarh, we have called Dr. Rajinder, who is only doing a lot of biopsies. He is only interested in doing biopsy. So you pick up one area. All the time, people used to laugh at me that I never do any nuclear cardiology and this thing. I told, okay, I do only therapy. That's, I love it. So I do it therapy. Not that I don't report PET scan. I don't report general nuclear, everything I do. But my heart, when it comes, it is with the therapy. So it started with thyroid, and I, whatever little bit I have achieved in thyroid cancer. So we do a lot of research, but the research which converts the change the practice globally, that is gives at the end of the day very big satisfaction. So if the 30 millicurie, whether estimable trial or halo trial, is only appendage of what I was all the time telling, that we can do the same thing with 30 millicurie, and they have confirmed whatever I've been observing. So that's fine. I have been born in India. If it would have been, I would have been professor in Harvard. I would have been even published in 2096 and in sorry 1996 and accepted in 2098 guidelines. It's okay, fine. Well, that is. But the idea which we just as a seed has grown as a big plant and now been accepted. And my lateral research is saying that for low risk thyroid cancer, you don't need any radioactive iodine. I've been telling for last 10 years, and fortunately that is also getting now been established by estimable to ion trial, everything we have published on 2,000 patients, saying that low risk patient recurrence rate is less than 1%. How can we further improve it to 0%? It's not possible. So it is, you need millions patient to say that 1% versus 99% versus 100%. It's not possible. So that's why. So it's, they don't need. Even if that 1% relapse, you can treat them, they will be better. So no need of punishing 99 people, because you 1% will be benefited. So you see, N is number needed to treat.
Number needed to treat.
It is only 20. If it is 100, you will never be successful in that. So that's what it is. So then the other area, when it came to the, because of my therapy interest, so when my first PhD student, I give this PSMA. Then before that, I had another patient, another PhD scholar who in 2007, we did this dotatate, lutetium dotatate. It's locally available lutetium from BRC we used to do, and I had experience. Then in 2012, another PhD student, I gave them dosimetry of lutetium PSMA, Madhav, who has got now more than 15 international awards. And then Sanjana was doing on actinium work. So she has also got 14, 15 international award. And this is how my team has helped me. And we have, as a group, we have published several. And I always give the first or third credit to my students. I always be the corresponding author. That's what.
Awesome. So I'm going to hand over to our upcoming ISNM president, Chitra Saxena, for the concluding question, and she'll take it from here. Chitra, ball in your court for the young professionals.
Okay, I'm going to take this now. First of all, we as ISNM, we would like to thank you from bottom of our heart, Dr. Bal, that you spent so much time, and we are truly inspired listening to your journey, truly. And especially, I must say, I admire your powerful mantra, which is, I picked it on pretty well. Embracing every challenge with the mindset, like you said, bring it on to me. I will make sure that I will take it and get it done. That's the biggest mantra for all our young professionals, mid-career clinicians who are pursuing a career in nuclear medicine and any other specialties. Thank you for being you. Thank you for being with us and sharing your amazing, scintillating journey. Thank you, Dr. Bal. Let's go all out and drink a chai.
One thing I wanted as my last word, I always wanted to, people used to say, you have done so many, why didn't you patent that? I don't know, I didn't want to patent anything, in fact. So to complete the story, finally, the FAPI molecule is now patented by us and one of co-inventor. I am one of the co-inventor in that paper. So now the Telix is taking to the next level. Hope that they will take the FAPI in a big way. In actinium dotatate, the Heidelberg University, they wanted to give intraarterially. I told anything you give intraarterially or intravenously, after 2-3 cycles of heartbeat, it will be all equilibrium unless there is something to hold it. And that I was proven right. So I changed from intraarterial, 7 patients, they did the pilot work on actinium dotatate as intraarterial. I give intravenously, and which is now been accepted, and FDA has now approved for the phase 3 trial to do it. So that is one of my satisfaction. So sometimes the science, your rational thinking is much important than just because somebody else is doing like this, I should do that. It's not necessary. It's not necessary. So if you are giving whether intraarterially or intravenously, after 3 or 4 heartbeat, the blood pool will be equilibrated. So if what the radiology interventional radiologist they do, they pack with the molecules which will not allow the material to come out to the venous circulation, or because it will not cross the capillary, so it will be stuck, but it can backflow, so you have to stuck from the arterial end. So, but if you are giving intraarterially just dotatate, it is a molecule. It will just go to the circulation, it goes to the IV, and it. So their argument that if you give locally, that will stick to the receptor and it will not. No, the body doesn't work in that way. We have not 100% extraction fraction that anything goes to the artery immediately get extracted and venous is 0. It's not like that. So they recirculate, then come back and get up. With time, you can see the uptake is always with time. So that is the rationality why intravenous and intraarterial intervention is always limited to few institutions. You cannot do but in intraarterial, even that is why radiotherapists are now telling we can do alpha therapy. Just give intraarterial injection, that can be done. So that sometimes it is very made simple. Anything made simple will also, a lot of people will be buying for the pie. So
Absolutely, absolutely. And I hope you are enjoying your USA trip.
yes,
So
I am
if
playing
you're
with my
planning,
grandson, just waiting outside. Nan, where are you hiding here? I don't know. I just finished my lecture.
and every day you're going to be innovating something. I'm sure you're innovating in USA as well, thinking what's next?
Yes.
What am I going to do next now?
Chitra, this is a golden time for nuclear medicine, particularly nuclear medicine therapy, because diagnostic side we have reached to the peak, maybe something new, some new molecule radiopharmaceutical come, but so far the instrument side and patient care side is we have, I think we have reached to the peak, but the therapy side is a big open field. You think anything you can, every molecule, every disease has a target. Only that target has to be identified and hit with the right type of bullets.
Yeah. Sounds good. All right.
Thank you.
Thank you all. Thank you, Dr. Bal.
Thank you.
Chitra,
Thank
thank you.
you
Amol, I
again.
know Amol for so long.
Absolutely. It was worth the wait. Thank you. Enjoy your Sunday. Thank you.
Bye.
Bye bye.